reach greater care in the short and long run. They have specialized knowledge and clinical experience from ambulatory care, critical care, solid organ transplantation, to even nuclear pharmacy. And for more information on the eligibility, requirements and related test information, you can actually go on the Board of Pharmacy Specialties official website. Oh, I didn't notice my camera was off. Sorry. And at the end of the day, our main goal as clinical pharmacists is to option, and that's by whether adjusting medication dose, frequency, the route of administration, to ensure the patient is receiving the correct treatment, and conduct therapeutic drug monitoring. And that includes just reminding the physician or even the nurse practitioner that this certain patient needs to have a medical test performed. And being able to identify adverse effects that can be as small as a rash or as severe as Stevens-Johnson syndrome. Now, being able to discuss with the physician on the different pharmacokinetic, pharmacodynamic properties according to the patient's clinical progression, and while constantly taking into consideration economic efficiency. Now, with all of those in mind, and hopefully we'll be able to achieve optimal patient outcome. Okay, so in order to truly become a competent clinical pharmacist, I think it really comes down to 6 domains. And the first one being, as I'll continuously bring it up, is being able to conduct direct patient care. And second is through licensure and specialized board exams, possess the basic pharmacotherapy knowledge needed, and which leads to the ability to care for specific populations such as the elderly and critically ill. Now, I think this one is the most important out of all: communication. I cannot emphasize enough how important communication is while working, and the way you try to bring across your suggestions, whether that is towards another healthcare professional or even a patient. There's a huge difference between that conversation. Now, when it comes to professionalism, clinical pharmacists should exhibit traits of responsibility, commitment to excellence, respect for others, honesty, integrity, and care and compassion. And last but not least, furthering your education and constantly acquiring for new knowledge. So, how do you become a clinical pharmacist? So most of us know about the US system, where you go to college, you obtain a bachelor's degree and that takes around 4 years, and followed by an extra 3 to 4 years of education in a school of pharmacy. Now, once you graduate, in order to kind of work, you'll have to pass the NAPLEX and NPJE. The NAPLEX, which is short for the North American Pharmacist Licensure Examination, is designed to evaluate general practice knowledge and is taken by recent college pharmacy graduates. Shortly after, this exam can also be taken by foreign educated pharmacists who have earned FPGC certification. Now, the latter, the multi-prudence exam, is designed to test your application laws and regulations for that specific state or jurisdiction you're going to. And if you look at 2019 passing rate, 8 out of 10 people passed. And among those, some will choose to apply for a residency program and continue for a second year, which would then specialize in a certain field of interest. Now, or you could just enter the workplace directly as a hospital pharmacist. What about in Taiwan? So it's definitely different. Since we have to choose pharmacy as a major early on before entering college, and then according to the college you're attending, it might take 4 to 6 years of education. And spoiler alert, but I would say that this is what we look like before entering the workforce, and hopeful with of what the future holds. And then once you graduate, some choose to further their education by applying for a master's degree, which that's exactly what I did. Or you can even choose a PhD degree. But in order to work as a pharmacist in Taiwan, you have to pass the official test, and that actually comes in 2 stages containing all of the following subjects listed above. And usually you're looking around 1,000 people passing every single year. So once you enter a hospital of your choice, we don't really have a residency program, but the first 2 years, we still call it your postgraduate years of training. And you get with the entire system, staff members, and gain more hands-on experience. And as time passes by with the accumulation of knowledge and experience, and of course, depending on whether there's an opening for the position, you then might transfer to the clinical pharmacy division or team, and as previously mentioned, work and develop into a competent clinical pharmacist. So I think the best way to kind of talk about what a clinical pharmacist does is to just simply show you guys what I do on a daily basis. And it really comes down to verifications, medical rounds, and dispensing, preparing medications. Okay, so I go to work and I turn on my computer, and this is pretty much the first thing I see. This is the exact same screen, but I'll try to translate it as I go. So I look at it and I get a good grasp of how many patients I'll be looking at for the day. And in this case, if you look at the red and blue boxes, are the wards I'm responsible for. And that includes the internal medicine intensive care unit, the respiratory care center, and ordinary ward located on the 6th floor, which mainly takes care of patients with any sort of cardiology associated problems. And I would say these numbers are on a good day. Since there's been a change in weather, and we've definitely seen an increase in the numbers of out-of-hospital cardiac arrest. So NICU on a full day would be looking at around 16 to 17 beds, and the RCC is looking at around 6 to 7. And when it comes to the ordinary wards, it's at least 45 patients or more. So I would be evaluating around 70 patients per day. Okay, so then I start assessing the patients, and the first thing that I look at is the main reason the patient was admitted, keeping in mind their basic information, their height, their weight, their age, and does he or she have any allergy records. Then by clicking on the red box, I'm able to see all the patient's medical records and within our hospital, including the last clinic visit. So as you can see, the patient had just been discharged in November. Then through the emergency physician's note, when I click on the second red box, sorry, there's like a huge delay. Yeah, so this actually pops up, and I get to see, I get to have a better idea of the patient's condition when he or she is admitted. So in this case, he doesn't have a fever, but his pulse and blood pressure are clearly elevated. Looking at his past medical history, he has hypertension and end-stage renal disease that requires a weekly hemodialysis session. So let's look at the SOAP. So subjective-wise, the patient came in with dizziness, vomiting during his HD session, and he indicated chest tightness, dyspnea, cold sweating, and abdominal pain. Objective-wise, his conscience was alert. His chest had a few crackle sounds, no wheezes. Abdomen was soft, no tenderness, and extremities were warm. Now, look at the analysis. What is the cause of vomiting? We have to rule out whether it's due to urinary stage. that's exactly what they did. So the physicians set up an EKG test, and they found ABR ST elevation. And as a result,
Hello, please mute your mic. Thank you.
Thank you, guys. And sorry, where was I? Yeah, so after the EKG test, it was ABR ST elevation, and as a result, they consulted a cardiovascular physician. And in this case, I would say it was a STEMI, so it's obvious the patient would have been pushed into the cath room and did a PCI, and most likely had a stent placed within whatever vessel was occluded. Okay, so moving on, once we collect the patient's national health card, we pass it through a computer system, and this can be done by any medical professional. I'm able to see all of the prescription that the patient has picked up within the past 3 months from any clinic, community pharmacy, and even hospital. So this process is crucial because I will then be able to detect chronic medication that should not be stopped abruptly, or I might even kind of notice the reason for omission. Let's say it's an elderly, he comes in with GI bleeding, and he has signs of acute kidney injury due to an infection, and I would once I notice that he's taking chronic medication, such as a direct oral anticoagulant, dabigatran, then I'd be able to further suggest our physicians, our medical team, that maybe we can use an antidote. Through this medication reconciliation process, I can also kind of suggest medication that should be re-prescribed once the patient is more hemodynamically stable. So since the patient, once they're admitted into the ICU, we place them on a sliding scale to control their sugar levels. But once they're more stable and ready for transfer towards the ordinary ward, it's your responsibility, the entire team's responsibility to realize and remember that you should put back their oral anti-diabetic medication. Okay, followed by other data such as the patient's cell count. You have to take into consideration, is there an increase in the white blood cells or band that might indicate a possible infection, or is the patient's hemoglobin's level still low, possibly due to continued signs of bleeding? And the good part about our system is it actually allows me to, once I click on top of it, you can see a trend, which I find really useful. And I think this is one of the crucial parts as well. You have to always be constantly tracking the patient's liver renal function. Is the patient on dialysis? What type of dialysis? Because when you're in an intensive care unit, it might be a CDVH, a SLED, HD. And when it comes to liver functions, when the patient's AST, ALT are increased, does the patient have hepatitis B or C? Have you conducted the necessary tests to determine that? So these lab data, they shouldn't simply just be a bunch of numbers to you. There's always meaning behind them, and your team will rely on you to give out evidence-based suggestions and adjustments accordingly. Now, when it comes to electrolytes, extremely important as well. Does there need to be a change of dilution when it comes to, let's say, antibiotics? When the patient has hypernatremia, hyperkalemia, can we change normal saline to dextrose? Diuretics, or are any current medications causing this abnormality that you're seeing in the patient's electrolyte status? So after they've been in the intensive care unit for a while and they've been using antibiotics for, I would say, a week or so, you have to look at the necessary cultures. So how many cultures or sets of cultures have you conducted? Is it reliable? Or do we need to change the patient's antibiotic treatment? Does when the patient has a fever and there's clinical progression, a rise in inflammatory markers, is the patient intubated? Or what are the amounts of lines that you see on the patient? The central, peripheral line, Foley, nasal gastric tubes, these are all sources and chances of infection. So in this case, as we can see, this sputum culture it would be considered a good quality culture. But the organism Serratia, according to each antibiotic and MIC, there isn't really a lot to choose from, since R indicates resistance pretty much. And these are just like CIP is short for ciprofloxacin, LVX is short for levofloxacin. And in this case, what we did do is we just suggested that we can consult an infectious disease specialist, and upon discussion, come up with a tailored, more specific treatment for this patient. And of course, the vital signs, that includes blood pressure, pulse, temperature, and respiratory rate. And sugar levels as well, not just hypoglycemia, but even hypoglycemia. These are more urgent situations that we will get notified through messages to immediately take care of them. Also, more detailed vital signs according to each shift by hours. And our main goal when it comes to MAP is to be above 65 mm mercury. And here you can see more detailed notes written by the main nurse, whether or not they're using inotropic agents or whether they have sedatives running still. But the most important of all is the patient's current medication. So what are they using currently? So as an example, this patient, as you can see above, the indication is acute myocardial infarction. And this type of patient, usually after after going into cath room and doing a PCI, it doesn't matter whether they have a stent placement or not, they should have a certain set of medication being given to them, and that includes a beta blocker, as you can see, bisoprolol, a dual antiplatelet therapy, which can be in the combinations of 3, such as aspirin plus clopidogrel, or aspirin plus ticagrelol, aspirin plus prasugrel. So followed by a statin, and then an ACI-ARB. In this case, they actually gave him a calcium channel blocker as well. So to me, this patient has all of the needed medication that he or she needs, and this is good to go. And then which leads to us later on a pharmacist-led consultation to individually show them image of the actual pill to increase their medication adherence later on before discharge. So when it comes to intensive care unit, we actually have weekly chart rounds, and this is our paper format, but it's basically formed by a multidisciplinary team, and it's crucial to have all of these members within your multidisciplinary team. And it's formed by a physician, and there might even be a resident, nurse practitioner, and of course, clinical pharmacist, social worker, nutritionist, respiratory therapist, and sometimes the occupational therapist or physical therapist. They're all crucial parts of the team, and they have to be present during your weekly chart rounds to have a very in order to achieve the best discussion. So everybody, sometimes when you're within these weekly chart rounds, you might notice a problem that other people didn't notice. And in that instant, when everybody's in a group, they can draw upon your opinion, your suggestions immediately, and that's the best care for that patient, because then you wouldn't have to be waiting on the phone for the physician to answer your question or kind of adjust the problems that you noticed. You can do it right then and there, and it will be a collaborative effort. So it's important to notice that data is power. Whatever you do, always document it. And as in this case, you can see our pharmacist-led consultations have greatly increases over the year, just from 2019 alone to 2020. And this is actually my favorite part. In the afternoon, I then go to the ordinary wards to conduct patient education. We tend to focus on patients admitted due to AMI and have undergone stenting or CABG. Also those with COPD and elderly patients with more than 5 drugs, in order to try to cut down on any polypharmacy issues. And this is why I love my job. when you get to interact directly with the patient you've cared for, you've seen him in the intensive care unit, and then he transfers to the ordinary ward, and eventually see them walk out of the hospital, knowing that with the correct advice you have provided, the time you've spent in some way or another, you've prevented the odds of another myocardial infarction occurring in the future. So I think it's really truly a rewarding, and this is the reason I do what I do every single day. Now, as you complete your consultation, there is always paperwork. So you have to document the information you have acquired for future references, as we later place these within the patient's medical chart. And as you can see, the top part is going to be the basic patient information, the name of the main physician, and of course your name as a clinical pharmacist. And the second column is going to be any patient allergy records, and of course information including past medication through the patient's national health insurance card. That's records, not just but past examinations, which prevents duplicate prescriptions and tests. So in turn, this really helps safeguards the patient's safety, and it improves on healthcare quality and reduces medical waste. And we try to conduct these medication reconciliation. We try to fill out these forms during visiting hours by talking to the patient or the patient's family members, and then you get a basic idea of their medication adherence, their family support system, and you need to jot down where your source of information is coming from. Okay, so always document what you're doing, and because later on it just might help you for research purposes, and in this case with other pharmacists, sharing with other pharmacists on an international level. So again, within a year, we've drastically increased our medication reconciliation services being given out. Okay. And here is just a few data. So as of now, our clinical pharmacist team, we have 6 pharmacists and 1 team leader, and we jot down every day working out days and the average amount of patients we see per day, bedside visits and interventions, and the rate of interventions being given. So I would say on an average, in 2020, September alone, our intervention rate was around 7.8%. Following is antimicrobial stewardship. So this is a coordinated program, as you all know, that promotes the appropriate use of antimicrobials, including antibiotics. And our goal is to improve the patient's outcome, reduce microbial resistance, and of course, decrease the spread of infections caused by these multi-drug resistant organisms. So when it comes to our hospital, we actually have a drug surveillance team, and that's led by our clinical pharmacist team. And we have a few key members, such as physicians, directors of cardiology from the Division of Cardiology, Infectious Disease, Nephrology, Neurology, and we have the nursing supervisor attending, and pathology and laboratory team leaders. So we conduct these meetings quarterly, and our main purpose and goal is to talk about any therapeutic drug monitoring, the drug use trends, and we conduct further analysis. We establish protocols, and that is why you need these directors present at these meetings in order to, it's not just you giving advice and pointing out issues, but in order to, once you establish certain protocols for changes, you need these people to pass on the word and support your decisions. And of course, we'll talk about certain pharmacist interventions and the overall physician acceptance rate. So it shouldn't be a shock that among the top 3 at first, when it comes to therapeutic drug monitoring trend, the most tests we conduct comes down to vancomycin, followed by valproic acid and digoxin. So knowing that you're conducting so many tests when it comes to vancomycin, drawing for its trough levels, that's where technology comes in. So we use technology to assist us and to prevent any possible errors from happening. So this is the screen that physicians see. So when they type in vancomycin and you're trying to prescribe it, they actually see the price of each vial, and according when they type in the patient's information, the computer draws for the latest renal function and their latest weight data, and then they compare according to this chart. So let's say the patient's eGFR falls around 50 to 59, within that range, but because of their indication, they have a certain they have pneumonia due to MRSA. So the physician would hope for a higher trough level that falls within 15 to 20 micrograms per milliliter. So in this case, the computer would then suggest, okay, so you can give vancomycin 500 milligrams 3 times per day. And I know this is in Chinese, but within the red box, it basically even reminds the physician that, okay, after 5 to 6 doses, remember to draw for vancomycin's trough level. And you need to do that 30 minutes prior to the next scheduled dose. And even when it comes to different forms of dialysis, so for hemodialysis, usually we just tell them to give 500 milligrams TIW, so that's after the dialysis session. And if the patient is under CVVA, after 4 doses before the next scheduled dose, remember to draw for vancomycin trough level. And then according to the data we get, we then discuss and we will adjust accordingly. So over the years, when it comes to antibiotics, we've been collecting data for at least 10 years, and we've seen a high occurrence of elevated amikacin trough levels. So every single year on average, I would say we conduct 15 to 18 tests drawing for amikacin trough levels, and among those, more than 41.18% indicate an overdose. All of this data, actually, we go back into the patient's medication records and we look individually to confirm that the dose, the frequency of amikacin given, and we make sure that the trough level was drawn correctly. So in this case, we found more than 318 cases. But if you exclude the patients not under dialysis, then you have 16 who were under CVVH, 120 with hemodialysis, and 1 under PD. And after you draw that all into Excel spreadsheet, it should look something like this. And then you highlight the ones that are patients have been overdosed, normal, or underdosed. And eventually you'll get data that indicates that there has been an elevated trough levels of amikacin observed and the decreasing trend in elevated levels of vancomycin. So when you're trying to prove a point, this is pretty much what you do. You collect data and you show it to team members in order for them to suggest. So as we know, amikacin's dosage, usually for a normal renal function, it's 5 to 7.5 milligrams per kilograms every 8 hours, or it's 15 to 20 milligrams per kilograms per day. But if we're talking about these patients with impaired renal functions, and as we've observed, those with intermittent hemodialysis, requiring intermittent hemodialysis, usually when it comes to the Sandberg guide, up to date, they still recommend around 5 to 7.5 milligrams per kilograms every 48 to 72 hours. But according to the data we've collected over 10 years and our retrospective analysis, Xinguang Hospital's Department of Pharmacy would then suggest that you use 3 milligrams per kilograms TIW in patients who are under hemodialysis. And that is actually supported and confirmed by our infectious disease division's director. So I just wanted to kind of share a case. And I think you guys will understand what I'm trying to say. So basically, this was an elevated vancomycin incident. It occurred last year around September. The patient was 97 years old with only 57 kilograms, a female. She had underlying coronary arteries diseases, including hypertension, and she had a stent done and has chronic kidney disease. Therefore, the poor circulation resulting in edema in all 4 limbs. Now, as you can see on September 8th, our clinical pharmacist got a message that notifying that the patient's vancomycin trough level was had greatly exceeded the goal range, which is usually below 20. Usually it's between 10 and 20, and in this case it was 41.7 micrograms per milliliters. Now let's see what happened. So the patient was admitted due to right buttock pressure sores and right foot wounds. So on September 4th, upon admission, the physician gave empirical antibiotics, vancomycin 1 gram once per day, and piperacillin tazobactam 2.25 grams every 6 hours, and clindamycin 900 milligrams every 8 hours as a combination therapy. So later on, post-pharmacist assessment, she suggested adjusting the vancomycin 1 gram once per day to 500 milligrams, so basically cutting the dose in half once per day. However, the physician insisted on a higher dose due to the wound's poor condition, which is understandable. And he later also consulted the ID specialist, one of the ID specialists, and the ID specialist replied saying that, yes, I think the dose does seem reasonable. So, okay, on September 8th, the lab results came back indicating an elevated vancomycin trough level of 41.7. And once the time drawn was confirmed to be correct, our pharmacist suggested to immediately hold the next scheduled dose and retrack trough levels the following day and wait for other cultures such as wound, sputum, blood, just for further assessment of the need of this antibiotic. Unfortunately, however, the patient then expired on September 11th. So let's look at the change in the patient's renal function and vancomycin trough level. So on the 4th, her baseline is around with a creatinine of 1.5 milligrams per deciliter, and that comes with an EGFR of around 32.13. Now, upon the pharmacist's suggestion, the physician didn't really change the total amount, but he changed the frequency to 500 milligrams twice per day, which still comes to a gram. And by the 7th, her creatinine started to increase to 1.61 with an EGFR of 29.61. So again, the lab results came out on the 8th with a vancomycin trough level of 41.7 micrograms per milliliter, which is pretty much twice the goal range we were trying to achieve. And somehow between there was a miscommunication. So vancomycin that morning, 200 milligrams stat was still somehow given, and they rechecked it on the 9th, and it was true. So vancomycin obviously was higher, 43.2, and the patient had an acute kidney injury later on. So I think what I'm trying to say is the suggestions you give as a clinical pharmacist, we're not trying to undermine the physician. I totally understand where he's coming from. Maybe this patient, when she came in, her status was rather severe, and he wanted to get the infection under control. But I think there's always the middle ground is we're all trying to save this patient. We're all trying to make this patient better, but at the same time ensure medication safety and efficacy. So I think, again, communication is key. Somehow something might have gone wrong in between here, but I think this is a great lesson for us to learn from. And as a clinical pharmacist, of course, we have to talk about the pandemic that we're going through as of now, which is COVID-19. Announced on the 12th March 2020 by WHO. It's important as a clinical pharmacist to always be up to date with your knowledge. So constantly looking at what's happening on a domestic level, not just domestic, but also international. As of so far in Taiwan, we have 870 cases confirmed, 7 deaths. And in the US, you're looking at around 24 million confirmed cases and 415,000 deaths. So it's really a tough time, and I think I mean we'll get through this together, and hopefully everything will look up after this. But how are we able to contribute? What are we able to do as clinical pharmacists? There's plenty we can do. especially in the hospital, because usually the patients we see are more severe. But the first thing you can do beforehand is to discuss. You can discuss with your peers, your multidisciplinary healthcare team, review reliable journals, clinical trials from ANJM, JAMA, and discuss before, during, and even after patient care. And then prepare. Being prepared is so important. So you have to ensure sufficient stock by tracking and tracing your in and out patient medicine usage. And as a result, with the early purchase of extra supplies, for in our case, for our hospital, we didn't really face an issue with shortage, which is a good thing. And if you want to know more greater detail about that, you can look into the FIP COVID-19 webinar that I participated in. Now, of course, monitor is crucial. So we know from the news that when it came to hydroxychloroquine and azithromycin, they kept on talking about QTC, prolonged adverse effects. So it is our responsibility as a medical team to closely monitor for these adverse drug reactions and promptly document them. Again, documentation is so important. Report and provide evidence-based suggestions. Then you can assist and apply. So provide up-to-date treatment protocols, drug information resources, and formularies. And in our case, I actually assisted our medical team in applying for the remdesivir clinical trial with the necessary documentations. And of course, when needed, acquire. So ensure that there is this timely provision of safe and effective therapy. For our pharmacy, it's actually 24 hours services. You can call in, any citizen can call in with any type of medical problem, and we'll do the best of our ability to resolve your issues, and of course, provide immediate care. Now, last but not least is to educate. So that's exactly what I'm doing, sharing your clinical experiences with both domestic and international pharmacists. And that includes through webinars, newsletters from IPSF, FIP. And once you do document, you'll get results. And for our hospital so far, we've treated 4 COVID-19 patients. 3 had rather mild and severe symptoms, but 1 actually developed rapid progression of respiratory failure, and then he required intubation and mechanical ventilation support. But what we did see were the common symptoms. So all of them had fever, had cough, and signs of sore throat. And this was around last year's March to April. So the treatment we gave was oral hydroxychloroquine, azithromycin, and zinc. Whereas the patient that was more severe within our ICU and required intubation received IV form tocilizumab and was specifically acquired, and this medication was specifically acquired. So our pharmacist actually went to another hospital to borrow this medication at that time and send it directly to the critical care COVID-19 patient's bedside. And eventually, all of these patients, and I'm happy to say, recovered and were discharged with a mean 22.25 days of hospitalization. And during that time period, there were more than 15 interventions conducted by pharmacists, including pharmacovigilance, medication review, and educational sessions that were carried out by pharmacists. So it's definitely really exciting to know that clinical pharmacists are able to participate and contribute. Okay, so following is education and professional development. So even as you enter the workforce, you can still further your education. It really just starts with you. You can still choose to go back to school. You can get a master's or even a PhD degree. And sometimes there are courses out there that allow you to get certificates in certain areas, such as smoking cessation educator or being a specialist within certain fields, as previously mentioned from BPS. Now, as a clinical pharmacist, it is our duty and our obligation to also teach the next generation. So that means pharmacy students who go on clinical rotations during the hospital. I think it's so important to pass on the knowledge that you have and experience and teach them, because you never know. these people who were once your student might later on become your colleagues. And that's really exciting. And I think the best part is sharing your experience, your knowledge, and allowing them to help even more patients along the way. And of course, as a clinical pharmacist, I'm not just teaching pharmacy students on a domestic and international level. I'm also teaching other healthcare professionals. So annually, I give out sessions to our critical care nurses about the most common drugs that we use, the actual images and what it looks like, and I answer their basic questions they may have. And usually, it's about dilute compatibility and whether this drug I can break it in half, or I can just grind it up because usually the patient has a nasogastric tube. These simple questions, but if you're there to answer their questions and help them resolve their issues, later on the road, they'll trust you and they know that in the time of need, you can help them and they'll always come back to you for more questions, which is really exciting. And I think that's the whole point of being a clinical pharmacist as well, knowing that you're being trusted by your team. So this is actually a program that we have with Howard University. It's a Howard pharmacy student and a pharmacist exchange program. So in this case, Ivan and Brianna came to Taipei, Taiwan, and in my case, I went to Washington, D.C. for a 5-week rotation, and we went into the intensive care unit, we went to the cardiology division, oncology, infectious disease, and I even got to go around with their transplant team, which was really exciting. But I think the whole point is being able to put what you learned into practice. And this is the Georgetown clinical pharmacist team, extremely amazing people, and I truly had a great time. And not just Georgetown Hospital, I also went to George Washington University Hospital and truly learned a lot. Following is not just on an international level. In Taiwan, we have our first of its kind clinical pharmacy specialist in cardiology program. So I just wanted to share this. This is actually an accredited cardiology pharmacist certifying program and competency standard. And it's actually established through the collaboration of the Taiwan International Pharmacy Advancement Association, short for TIPA, and the Taiwan Society of Cardiology. So this accreditation program aims to integrate clinical medicine and clinical pharmacy, where certified pharmacists will specialize in the delivery of direct patient care and to ensure safe and effective use of medication in patients with cardiovascular diseases. Now, our program consists of 4 dimensions, and that includes knowledge, skill, practice, and attitude. Now, the lectures within the program are then dividing according to 4 main CV topics, and that includes acute myocardial infarction, congestive heart failure, hypertension, and cardiac arrhythmia. So this knowledge-based training program is carried out through a flipped classroom model where lectures are uploaded online and they are accessible anytime, anywhere for our students. And outside of class, the various skill-based training programs are also adopted. For example, interpretation, the physicians actually teach us how to interpret pathophysiology and laboratory data, evaluating medication treatments and identifying possible adverse effects, conducting case-based discussions and applications, reviewing journals, participating in daily bedside visits. And the clinical pharmacists are then assessed by OSCE, DOPS, mini-sex. And finally, after more than 400 hours of intense training, as of now, we have 9 cardiology specialized clinical pharmacists located among 6 of the participating medical centers in Taiwan. So consequently, these certified pharmacists, they will then be working closely with the Division of Cardiology to provide more in-depth and patient-centered care. Okay, so I just wanted to share this interesting case where our director of the division of cardiology actually phoned me up and said, can you come and give a clinical pharmacist-led consultation for one of my patients, because I'm really busy. And of course I said, yes, that's part of my job. I'm here to alleviate your workload. So this patient is 90 years old, 50 kilograms, and has these certain past medical histories, and has a pacemaker and dentures. But the point is, as we look at her clinical course, her LDL in 2020, June of 6, was 185. And despite after 2 to 3 months of chronic medication, including aspirin, clopidogrel, midodrine, atorvastatin, lansoprazole, and nebivolol, by the time she did her recatheterization in September 2nd, her LDL did not decrease, and her triglycerols, total cholesterol, as you can see, actually increased over time. So once I conducted my pharmacist-led consultation, what I noticed was she had a bad habit. She had no recollection of atorvastatin, so it was a confirmation of drug loss, and she was taking incorrect drug frequency, and she had stock of other medication that she was not taking. So this is a SOAP that I actually wrote within the patient's medical records, and basically analysis is the patient indicates that she takes around 8 pills in the morning. Once she picks up her chronic medication, she would then throw away each individual bag, which would lead her to only take pills that she is familiar with. So when I showed an image of atorvastatin's outer package and pill, the patient had no recollection and most likely did not take it, hence the elevated LDL levels. So followed by that, instead of half a pill twice per day, the patient would take nebivolol at a once per day, one pill frequency with fear of hypotension. And she also admitted that she hasn't really been taking it for over a month. So, and as we kind of continued our conversation, the family member indicated that the patient has a lot of stock when it comes to calcium acetate, and the last time her medical records show, she collected it in April, so it shouldn't make sense. But these are the kind of problems that you will only find out if you talk to the patient yourself. And so what we're doing as a clinical pharmacist is we're integrating past and present medication. We're asking, we're listening to the patient, family member, caregiver. We're assessing whether there's a drug or food interaction, whether patients are taking herbal supplements on the side. We're educating them. We're ensuring that through our education, we can improve the medication adherence. And last but not least, we're recording. We're recording detailed descriptions for future effective assessments. And this is my team, or I could say my family. And I think it's really important as a clinical pharmacist along the way. Sometimes you make friends without even knowing, and it's really important to have that work-life balance. So at the end of the day, who can help? You guys are the one who can help. We're all part of this, and we can lead by example, by wearing a mask, by spreading the news of getting fully vaccinated. And I think if I were to choose again, I would still be a clinical pharmacist, because it's truly rewarding knowing that what I do every single day is helping someone and their family member. So yeah. Thank you for having me, and hopefully I can answer any questions you guys have. Mary?
Okay, thank you so much, Dr. May, for the amazing webinar. I learned a lot on medical reconciliation, on how clinical pharmacists can solve polypharmacy issues. I also learned a lot about data, how data is so important in clinical pharmacy. I really enjoyed the webinar. I'm sure a lot of people enjoyed it too. Please, during the webinar, kindly focus on the information being shared. A post-webinar evaluation form has been put in the chat box. Please kindly fill this form. The IPSF will work towards making a certificate of attendance available, and the data will be collected based on the post-evaluation webinar form. So please kindly fill the form so you can have access to possible certificates. Now we're in the question and answer session. Our time is really fast spent. So please, we'll take about just 2 to 3 questions. Please put your questions in the chat box. Thank you. Okay, someone asked that what is a SOAP? What does SOAP stand for? Dr. May, can you do just that and explain what the SOAP approach is?
Yes, SOAP is short for Subjective, Objective Assessment and Plan, and it's a very critical skill that you need to have once entering the workforce, because it will be documented on the patient's medical chart, and that's what other, not just you, your colleagues, but other medical professionals will be looking at. Yeah, that's basically what I did for that specific 90-year-old patient.
Okay, thank you. Another question was, what is the role of data science in pharmacy? The role of data science in clinical pharmacy?
The role of data science, it's extremely important. Like I previously mentioned, with the data if I'm understanding this correctly, with the data you have, such as antimicrobial stewardship during our drug surveillance team meetings, you're able to prove a point basically, and you're able to later on share your research as well, not just to benefit your own organization, but later on to kind of teach other health professionals as well. So I think it's really important to, like I said, document everything you do, the interventions that you have conducted, and yeah, that's pretty much it.
Okay, please put your questions in the chat box. Someone asked a question on masks and COVID-19. Dr. May, do you want to shed some light on that?
Of course, I think it's, as we all know, wearing a mask, it shouldn't be political. It's not just about protecting yourself, but protecting other people. So sometimes when you've contracted COVID-19, you might not display any signs. You might, but you never know who that person sitting next to you is. They might have immune compromised, or they might have multiple comorbidities, and once they are contracted with COVID-19, they might not make it. So wearing a mask is of course vital during COVID-19, and I think it's extremely important to lead by example. That's why when we enter, anyone that enters our hospital, you are required to wear a mask. And yeah, especially when it comes to vaccination, I think it's important to spread the word as well. Thank you.
Okay, I have another question. How, as clinical pharmacists, do we convince physicians, that's doctors, on medication errors, on probably changing prescriptions or drugs recommended? But how do we relate with physicians to change their recommendations?
Oh, I definitely understand what you're trying to get at. So when I first entered my job, it's definitely not easy. Once in a while, you come across a physician, such as the elevated vancomycin trough level incident. That physician did not take the clinical pharmacist's suggestion, and you could see what happened later on. But I think it comes with time. Over time, they will ask you questions, and it really depends on your professionalism, your knowledge, whether or not you're able to answer their questions during that time period. After 1 time, 2 time, over, and they realize like, oh, maybe you know what you're doing, and you later become kind of like a family, like me and my medical team as of now, and they will take into consideration your suggestions. Or even if you do come across someone who is very strong-headed and is not willing to take your consideration, just show them the evidence. You can show them data, articles, or just evidence-based, that your suggestions are evidence-based. I think that's the best way to kind of convince physicians, but I think it definitely takes time. It's a working process, but at the end of the day, the main point is we're trying to give the patient the best care. We're trying to ensure their safety, and we're trying to ensure that this treatment is efficacious. Thank you.
Okay, thank you very much, Dr. May. Please kindly fill the post-webinar evaluation form, and we'll be working on getting certificates across to participants. Okay, is there any other question? Okay, indeed. Okay, I'm seeing a question on the COVID-19 vaccine. There are questions on side effects and its safety.
Oh, yes. So as of now, in Taiwan, we don't have the vaccination process underway. But so far, from what I've seen and what I've heard from my friends in the States, they haven't had any side effects besides soreness from the site of injection. But any type of medication there might lead to a different result for every single person. So I think at the end of the day, getting vaccinated is something that we should support, and as pharmacists to push for, and not kind of give into the what hearsay on the websites and online. So getting vaccinated, I don't know about whether if the person has had COVID before or was later cured, but I think vaccination is crucial to prevent the further spread of this pandemic. Thank you. I do see people saying
Okay, thank you very much, Dr. May. The International Pharmaceutical Students Federation is really honored to have you here with us. So in the absence of any question, we'll be ending today's webinar. Please follow IPSF on all social media platforms to get updates on our webinar series and other very important information. Thank you all for joining today's webinar session. The webinar will be ending now. You can put on your screen, put on your video, and say bye as we end the webinar.
Thank you, guys.
Bye.